Okay, shall we start now? Okay, so good morning, everyone. My name is Ms. Nichiwan from GALS, Academic Officer of Center for International Affairs, Walilah University. Today is a very honor to welcome Ms. Caroline Call, Medical Doctor from Ohio State University, and C. Chandana, Medical Doctor from Ohio State University, to talk about what you need to know about hypertension and obesity. Okay, so the topics of today is about the management of hypertension in the outpatient setting. She will talk about epidemiology, right? And how to define hypertension and important considerations and why the hypertension is important. And for the obesity, it's about lifestyle modifications, dietary approaches to stop hypertension, and pharmacotherapies. So now, please welcome Ms. Caroline to give a talk on management of hypertension. Please welcome.
Hello, thank you everyone for having me. My name is Carolyn Cow. I will be sharing my screen. I will be speaking about obesity and weight management. This is not working. Let me see. Sorry, I'm having technical difficulties.
That's fine.
Okay, can you see my screen?
Yeah, I can see it now.
Okay, great.
Oh.
Okay, so here is my presentation. So this is an outline of my presentation. First, I will be talking about assessing obesity and the various definitions. Then I will be talking about why obesity is important, and that is because obesity is common, serious, and costly. Next, I will be talking about management and treatment, including lifestyle modifications, pharmacologic therapies, and bariatric surgery. So first, body mass index, or BMI, is an estimate of your overall body fat. And this is calculated by dividing the weight in kilograms by the height squared in meters. Based on the risks of death, diabetes, hypertension, and coronary heart disease associated with different BMI values, the NIH, National Institute of Health, and the WHO have developed classifications for weights based on BMI. It is important to note that these BMI values that we use in the United States are only for Caucasian, Hispanic, and Black individuals. As you can see, the BMI is separated into different categories, with obesity being a BMI of over 30, and then they classify class 1, 2, and 3 obesity depending on the severity. Here is a chart about body mass index. So looking at weight and height, you can see where the BMI would lie. So it is important to note that these classifications underestimate the risk of type 2 diabetes and cardiovascular disease in Asian and South Asian populations. So the Regional Office of the Western Pacific created BMI classification specifically for this population. And as you can see, they say that class 1 obesity starts at BMI of 25, which is significantly lower than the BMI of 30 that I had mentioned before. In addition, BMI may be a poor estimate of adiposity in certain patients. For example, professional athletes may be heavier because they have increased muscle mass. In addition, patients with anasarca or end-stage liver disease may have increased body fluid to create increased weight as well. I have a few questions in this presentation. So the first one is, which one of the following individuals is considered to be at high risk for morbidity and mortality related to his or her weight? First is A, a man with BMI of 28 and waist circumference of 38 inches. B, a man with BMI of 24 and waist of 41 inches. C, a woman of BMI of 26 and a waist circumference of 33 inches. D, a man of BMI of 28 and waist circumference of 41. E, a woman of BMI of 28 and waist circumference of 33 inches. The answer is D, and I will go over why. So the role of waist circumferences. So while BMI gives you an estimate of your total body fat, waist circumference or the distribution of body fat may be a better predictor. So individuals with more abdominal fat have been shown to have greater risk of mortality and morbidity. So that would be considered greater than 40 inches in men or 35 inches in women. Overweight and class 1 obesity patients with increased waist circumference indicate an elevated risk for these comorbidities compared to patients who are similar with normal waist circumference. So as you can see here, it is really important to take a look at waist circumference to determine if patients have an even elevated higher risk of these comorbidities. So why is this important? As I mentioned before, obesity is common, serious, and costly. This was taken from the CDC, and as you can see, 1 in 5 children and more than 1 in 3 adults struggle with obesity. Children with obesity are more likely to have obesity as adults in addition, and then they're at risk for several of these risk factors that I will go over, and then obesity is also costly, which I will go over as well. So obesity in the United States, currently the prevalence of obesity in the adults in the United States is over 40%. And actually from about 2000 to March of 2020, the prevalence has actually increased from 30.5% to 41.9%. This is important because individuals with obesity have higher rates of death from all causes. And in fact, young men and women with very high BMI, greater than 45, could be expected to die between 5 and 20 years earlier than their non-obese counterparts. And for children, the prevalence of obesity was about 20% and affected 14.7 million children and adolescents over the country. So here is a map of the United States, and as you can see here, the prevalence of obesity is quite high in almost all of the states in the orange coloring, so about 30 to 40%, and there was only one state or area, and that is Washington, D.C., and their rate of obesity is only 20 to 25%. I took a look at the numbers in Thailand, and the prevalence of obesity in the Thai population was performed by the National Thai Food Consumption Survey in 2018. Using BMI classification by the Regional Office for the Western Pacific, as you can see here, 17% of adults were classified as overweight, 19% as class 1 obesity, and almost 5% as class 2. So when comparing obesity prevalence using this definition, about 23.8%, this was almost 5 times greater than what defined by the WHO standard that we use in the United States. In comparison, as you may remember, obesity prevalence in the United States is almost 42%, so this is quite a big difference. Next, I'd like to talk about the association of body mass index with healthcare expenditures in the United States. So this was a study that looked at BMI-related healthcare expenditures from 2011 to 2016 using this survey. And they found that the estimated annual medical cost of obesity in the United States was nearly $173 billion in 2019 dollars. In fact, annual medical costs for adults who had obesity were more than $1,861 higher than medical costs for people with healthy weight. And they found that each increase in BMI per unit was associated with an additional cost of $253 per person. Here are various obesity-related comorbidities. As you can see, it can cause effects in almost all of the systems. So for example, endocrine, there's diabetes, cardiovascular disease with hypertension, heart disease, atrial fibrillation, cancer. There are multiple different cancers that you're at increased risk for. Renal system, you can have chronic kidney disease or kidney stones, various genitourinary effects, neurologic infections, and gastrointestinal effects as well. For pulmonary, I want to point out obstructive sleep apnea and restrictive lung disease that may be common with higher rates of obesity. You can get musculoskeletal complaints with osteoarthritis or chronic low back pain. And then it's always important to remember psychological effects, including psychiatric like depression and anxiety, and also social stigmatization. I want to talk briefly about metabolic syndrome, as I mentioned, with increased adiposity in the abdominal area. If you're diagnosed with metabolic syndrome, that puts you at risk for all of these various conditions. This is the diagnosis for metabolic syndrome. So if you have any 3 of these 5, you will be diagnosed with metabolic syndrome. So that includes elevated waist circumference, as I mentioned before, elevated triglycerides, reduced HDL, or if you're on drug treatment for dyslipidemia, elevated blood pressure, so that's over 130 over 80 or 85, or if you're on treatment for hypertension, and then elevated fasting glucose, or if you're on treatment for it. Next question, a 54-year-old female with a BMI of 31 presents for a physical exam. Which of the following is the most appropriate initial recommendation for weight loss? A, reduction of caloric intake below 1,000 calories a day for a month to jumpstart her weight loss. B, recommend weight loss of 20% of the current weight in 6 months or a 4 to 5 pound weight reduction per week. C, assess previous attempts at weight loss before recommending an option. And D, refer for bariatric surgery. And the answer is C. So, talking with your patient about their weight. As I mentioned before, there is a lot of social stigma and shame that may be associated with weight gain or obesity. And so it's important to start the conversations with sensitivity towards your patient. Some things to assess are, their weight and lifestyle history, assess their readiness to make any lifestyle changes, and then weight management counseling, including creating SMART goals, which are specific, measurable, action-oriented, realistic, and timely, and then motivational interviewing to continue to help your patients achieve those goals. So here are some examples on how to start the conversation with your patients. It's always nice to ask for permission to talk about a certain topic that may be sensitive. So for example, you could say, would it be all right if we talked about your weight today? You could ask open-ended questions such as, what do you think about your weight? Or you could ask if, concerns for if your weight is causing problems. You could do some education in terms of talking about the BMI. So for example, based on your height and weight, your body mass index is 40, which falls into the obese category. Next, here are some specific aspects to include in your history taking. So for example, you would want to ask specific questions related to obesity-related comorbidities. So for example, type 2 diabetes or osteoarthritis. Next, you can ask about weight loss goals, along with information about their weight trajectory in their past, their diet history, information about their physical activity. In addition, psychologic aspects such as emotional eating, support if they have any anxiety or depression, and then assessing sleep as well. Next, you can assess readiness. So you can ask questions like, are you interested in talking about your weight loss and working together to make a plan? You can also ask how prepared they are to make any changes, and then also ask who in their life will support them during this journey. And then for us in the United States, we always have to keep in mind of costs of different medication therapies, which I will talk about next. So here is the next question. A 45-year-old man has a BMI of 39 and is looking to lose weight. Which one of the following caloric deficits would you recommend for him to achieve safe and effective weight loss? And the answer is 500 to 750 fewer calories per day. So setting goals. First, understanding your patient's motivations and expectations can help you set goals. Patients should have an initial goal of losing 5 to 10% of their current weight over the next 6 months. So a reasonable goal for weight reduction in patients with a BMI of 27 to 35 is losing half a pound to a pound a week by reducing the caloric intake by 300 and 500 calories per day. For patients who have BMI greater than 35, like our example question that I just went over, they should reduce their daily caloric intake by 500 to 1,000 calories a day with the expectation of losing 1 to 2 pounds per week, about 10% of their current weight in 6 months. Here are just some dietary resources that you can show your patients. So for us, this is myplate.gov. So this gives visuals of how to plate their food in terms of getting all the categories of food groups. Next, this is the dietary guidelines.gov showing different food groups that are recommended, like whole fruits, whole grains, low fat or fat-free dairy, vegetable oils, lean meats, and veggies. This website I think is very interesting, is a food database that will give you information about different, popular fast food restaurants and brands. So for example, I'm not sure if you guys have Wendy's here, but it's very similar to McDonald's. So for example, Wendy's spicy chicken sandwich has 500 calories and it gives you the grams of fats, carbs, fiber, and protein, in addition to estimating how much you would have to do to burn off the 500 calories. Next, I want to talk about popular diets. So in a 2014 systematic review comparing different diets, they found that there is weight loss with both low fat and low carb diets at 6 and 12 months, and the weight loss differences between these different diets were very small. Other studies have shown significantly greater weight loss at 6 months in low carb diets compared to low fat diets, but no significant difference at a year or 12 months, or a year or 2 years. In addition, it is important to remember that dietary changes must be maintained to prevent weight regain. So here's a chart of different common diets. So for example, the Atkins diet is low carb, which may increase your HDL and decrease levels of triglycerides. The low glycemic index diet can help with weight loss outcomes for people with insulin resistance or diabetes. The Mediterranean diet can lead to improved blood pressure, lipids, and glycemic control. Another one that's very popular is the DASH diet, which is low salt, which can help reduce blood pressure and cholesterol. Next question, which one of the following would be an appropriate initial physical activity recommendation for a patient who would like to lose weight? A, advise the patient to take a 30-minute walk each day. After 3 months, advise him to exercise vigorously for at least 3 days a week. B, discuss a physical activity plan to gradually increase the intensity and duration from the current level, doing an activity that he enjoys and has access to. C, encourage the patient to join the YMCA or another gym to receive professional training. D, suggest that he rise earlier and ride an exercise bike while watching the morning news. E, recommend that he engage in 45 to 60 minutes of aerobic activities 3 times per week and strength training 2 times per week. And the answer is B. So here is the recommendations given from the WHO. So the general recommendation is 150 minutes per week of moderate intensity exercise or 75 minutes per week of vigorous exercise plus strength training at least 2 times a week. You may achieve additional benefits if you increase that number of minutes per week, and you may require even more with weight loss. And then according to the 2013 AHA and ACC guidelines, increased activity for at least greater than 150 minutes per week is an integral part of a comprehensive weight loss program along with diet and behavioral strategies. In the absence of dietary changes, exercise alone only results in a mean weight loss of about 0.1 kilos per week for a total of 2 to 3 kilograms, which is about 0 to 3% of initial body weight in 6 months. Of course, if you're doing very high levels of exercise and increasing your calorie deficit, you may lose more weight. If your patient is not physically active at baseline, then setting an initial goal of 60 minutes per week or 10 minutes per day for 6 days a week may be reasonable, and then encourage them to slowly build it up over a few months to meet the goal of 150 minutes per week. It is also important to reduce the total amount of sitting time during the workday, and exercise is also very important for maintaining a weight loss, and up to 300 minutes per week of moderate intensity exercise may be needed to keep that weight off. So here is a summary of what we have talked about so far. So the treatment of obesity or being overweight is indicated for all individuals with BMI greater than 30 and those with BMI greater than 25 with an obesity-related condition. And again, I'm using BMI that we would use in the United States for that Caucasian, Hispanic, and Black population. In order to talk to your patients about losing weight, you need to assess their readiness to lose weight, and you should only counsel patients who are ready. And all treatment plans should include a combination of dietary modification, physical activity, and behavioral strategies. An initial goal should be 5 to 10% loss of body weight over 6 months, followed by weight maintenance. Question: for which of the following patients would the addition of pharmacotherapy for weight loss be appropriate, along with lifestyle modification, including dietary changes? And so the answer is A, a 50-year-old man with normal blood pressure and glucose and a BMI of 31. I will go over why. So pharmacotherapy can be considered as part of a comprehensive program for the following patients. If your patient has a BMI greater than 30, as was our answer choice patient, or if a patient has a BMI between 27 and 30 and at least one obesity-related comorbid condition. For example, hypertension, dyslipidemia, type 2 diabetes, or sleep apnea. So pharmacotherapy, typically monotherapy in combination with dietary and physical activity behavioral interventions, can lead to 6 to 8% of total body weight loss. Although there have been some recent medications that may cause even greater weight loss, which I will go over as well. During the first 3 months of therapy, weight loss of greater than 5% of total body weight is considered effective and should be continued for long term if it is approved. It is very important to note that no matter which agent is used, weight is often regained after cessation of the medication. And insurance coverage and out-of-pocket costs vary widely. So next, I will go over the FDA-approved medications for obesity for long-term use or greater than 12 months. The first one is Orlistat, which is a lipase inhibitor. This inhibits the hydrolysis of triglycerides into free fatty acids. So these triglycerides are excreted undigested and reduces fat absorption by about 30%. There is a warning of severe liver injury with this medication. So this chart I will use for each of these long-term medications. So the approximate cost per month is about $600, which is quite expensive. The mean weight loss over placebo was about 2.6, maybe up to 3 kilograms at 12 months. And common side effects are diarrhea, flatulence, abdominal pain, and deficiencies of fat-soluble vitamins. The next medication is a combination called phentermine and topiramate. So this is a combination appetite suppressant. You have to have caution in using it with women of childbearing age, as it is linked to risk of cleft lip when taken in the first trimester of pregnancy. This medication is about $200 for a month's supply. And as you can see, there is quite significant weight loss seen, about 10 kilograms lost at 12 months in comparison to placebo. Common side effects include constipation, dry mouth, paresthesia, suicidal behavior, and birth defects, as I mentioned. Next is another combination called naltrexone and bupropion, which may affect the reward system that is involved in the regulation of food intake. There's a risk of suicidality in bupropion in the setting of depression, and naltrexone can also precipitate opiate withdrawal. This medication was seen to have an average weight loss of about 4 kilograms at a year. And common side effects, as I mentioned already, you can also have increased risk of seizures, hypertension, liver toxicity, and opiate withdrawal. Next is GLP-1 agonists, which have been very popular in the United States. So there are 2 GLP-1 agonists that are approved by the FDA for obesity, and that is liraglutide and semaglutide. So this causes weight loss with appetite suppression and slowing gastric emptying. GLP-1s are already commonly used for the treatment of type 2 diabetes. Different agents are more commonly used for that. But as you can see here, it is very, very expensive, about $1,200 a month or $1,400 a month. And this is given as a sub-Q injection. So liraglutide is given daily and semaglutide is given weekly. Semaglutide has an extraordinary response for weight loss. As you can see here, they found to have a weight loss of about 15 kilograms at 14 months. Common side effects are nausea, hypoglycemia. You also have to be mindful if patients have history or family history of medullary thyroid carcinoma and thyroid tumors. This would not be recommended. In addition, pancreatitis risk. We would also not recommend taking these medications if you have that. This one I thought was very interesting. This one is called Plenity, and this is an ingested transient space occupying device. So it is actually not digested in your GI system at all. It is a gelatin capsule that contains particles that will expand with taking water to create a feeling of fullness and lead you to eat less food. This is actually FDA approved for patients with a BMI between 25 and 40. And in their clinical trial, they found that patients lost on average about 10% of their body weight in 6 months. And the most common side effects were feeling full, bloating, or abdominal pain. And it is less expensive than the other options that I had mentioned before, maybe about $100 for a month's supply. Next, we can talk about the FDA-approved weight loss medications for short-term use. So this is up to only 3 months. There are 4 medications that are all sympathomatic appetite suppressants, and they have similar side effects like insomnia, tachycardia, hypertension, feeling nervous, dizziness, tremors, constipation. And here's a chart of the 4 medications, so the phentermine, diethylpropion, phendimetrazine, and benphentamine. Here are the various prices, and these are quite affordable as well. Next question. This is a 38-year-old woman who is seen in the office to discuss pharmacotherapy for obesity. She has not lost significant weight over the past 6 months despite dietary counseling, commercial weight loss programs, and exercise. Medical history is significant for nephrolithiasis, insomnia, hypertension, and irritable bowel syndrome with diarrhea. She takes hydrochlorothiazide and loperamide. On physical exam, vital signs are normal. Her BMI is 39. Which of the following is the most appropriate management? A, liraglutide, B, naltrexone bupropion, C, orlistat, or D, phentermine topiramate? And the best answer is liraglutide. So liraglutide would be most likely best tolerated in this patient. As I mentioned, contraindications for this medication would be a history of medullary thyroid carcinoma or family history of MEN type 2, and you should also be cautious in using it in patients with pancreatitis. She has none of those, so it'd be most likely that she would tolerate this the most. For naltrexone bupropion, it would be a poor choice for her given the side effects of insomnia. It's important to note some other contraindications for naltrexone bupropion would be seizure disorders, eating disorders, any opiate use or withdrawal, and any risky alcohol use. Next, orlistat can cause gastrointestinal side effects, including oily stools. And so this would be a poor choice for this patient given her history of irritable bowel syndrome with diarrhea. Next, phentermine topiramate contraindications would be glaucoma, hyperthyroidism, and nephrolithiasis. So you would want to have caution in using this with patients with hypertension or resting tachycardia. In this case, it is contraindicated because the patient has history of nephrolithiasis. Next question, which of the following individuals is considered an appropriate candidate for bariatric surgery? And the answer is C, a 28-year-old man with BMI of 37 who has type 2 diabetes and hyperlipidemia. Bariatric surgery is currently indicated in any individual with BMI greater than 40 or any individual with BMI greater than 35 who also has significant obesity-related comorbidities. In addition to weight loss, bariatric surgery leads to improvement in most obesity-related comorbidities. So this is quite impressive. Up to 73% of type 2 diabetes resolve, up to 63% of hypertension, up to 78% of sleep apnea resolve. And you can also have improvements in your lipid levels, your mobility, return of fertility, and quality of life. The only weight loss method to show a reduced long-term mortality. Here are average results of bariatric surgery type in the United States. So there are 3 common types. The first is Roux-en-Y gastric bypass, sleeve gastrectomy, and adjustable gastric band. As you can see at the 5-year mark, Roux-en-Y gastric bypass caused the most initial body weight loss, so about 25.5%. In comparing these various types, here are some pictures of the different types of the gastric bypass, the vertical sleeve, and the gastric band. So Roux-en-Y, as I mentioned, produces the greatest weight loss, but has also the most complications, such as nutritional deficiencies. Sleeve gastrectomy has similar weight loss results and lower rates of complications except for GERD or gastroesophageal reflux, and gastric banding has actually fallen out of favor given need for reoperations. So this is a treatment summary of what we have talked about. So weight management is indicated for all individuals with BMI greater than 30 and BMI greater than 25 with an obesity-related comorbidity. You would reach for pharmacotherapy for all individuals with BMI greater than 30 and greater BMI of 27 if they have an obesity-related comorbidity. And then bariatric surgery is indicated for all individuals with BMI greater than 40 or BMI greater than 35 with comorbidities. Here is just a flow chart in terms of managing weight. So first, checking the weight, BMI, and waist circumference along with the patient's risk factors. You would recommend lifestyle recommendations like reducing your caloric intake, increasing physical activity, and then behavioral therapy as well. If indicated, offer FDA-approved medications to treat overweight or obesity when indicated, and you would recommend offering bariatric surgery when indicated as well. Finally, it is important to manage any comorbidities that the patient may have, and that includes dyslipidemia, hypertension, and type 2 diabetes. Here are my references, and that's it. Thank you very much. Any questions?
Thank you for your presentation. It's very useful information. Yes. Does anyone have any questions? Please feel free to ask. Okay, so I don't think we have the questions at the moment. Maybe later after the presentation of Chandra, right? She will be present next to you, right?
Yes, Shri will now be presenting on hypertension. I'm going to pull up her PowerPoint here. Okay, can you see this okay?
Yes, I can see.
Okay, great, thank you.
Hi. Okay, so now we are meeting with Ms. Sri Rajamuri from Ohio State University, and she will talk about the management of hypertension in the outpatient setting. All right.
Perfect. Hello, everyone. I'm Shri. And like she said, I'll be talking about hypertension. So our learning objectives for today. So first we'll talk about the epidemiology. Then we'll talk about the definition of hypertension, how to diagnose hypertension, important lab testing and physical examination findings, other important definitions like secondary and resistant hypertension. And then we'll talk about the treatment and management, including dietary and lifestyle changes and pharmacotherapy. So hypertension is actually one of the leading risk factors for cardiovascular disease and disability worldwide. So in the US, hypertension is actually only second to smoking as a risk factor for death and disability. The prevalence of hypertension varies based off of what you use for the cutoff point. So it actually increases from 32% to 46% when you change the cutoff from a blood pressure of 140/90 to 130/80. About 90% of patients with hypertension are identified as having primary or essential hypertension. So there's no other underlying secondary cause for causing this hypertension. How exactly do you define hypertension? So normal blood pressure is less than 120/80. Elevated blood pressure is between 120 to 129 systolic over less than 80. Stage 1 hypertension is defined as 130 to 139 over 80 to 89. And then stage 2 hypertension is defined as greater than or equal to 140/90. So the American College of Cardiology and the American Heart Association defines hypertension as a blood pressure greater than or equal to 130/80 or stage 1 hypertension. So some other important considerations. So there's office hypertension or white coat hypertension, as we call it. And so office blood pressure readings are often higher than their home blood pressure readings that the patient brings in. There's also masked hypertension, which is when the office blood pressure readings are actually lower than their home blood pressure readings. You should really consider masked hypertension in patients that have evidence of target organ damage, so coronary artery disease, cerebrovascular disease, or strokes, peripheral arterial disease, chronic kidney disease, but they don't actually have a diagnosis of hypertension based on their in-office readings, but sometimes they consistently have elevated blood pressures. So why is it important to talk about hypertension? So hypertension increases your risk for cardiovascular disease, cerebrovascular disease, peripheral arterial disease, aortic aneurysms, heart failure, and chronic kidney disease. For every 5 millimeter mercury increase in diastolic blood pressure and for every 10 millimeter mercury increase in systolic blood pressure, both of these are associated with a 28% increase in the risk of death from coronary artery disease, which is actually pretty significant. So who exactly should we be screening for hypertension? So the United States Preventative Services Task Force, or USPSTF, recommends screening for hypertension in adults greater than or equal to 18 years old who are at risk for increased cardiovascular disease from hypertension. It's important to start interventions early. Adults that are aged 18 to 39 that have a blood pressure less than 130 over 85, but they don't have any other cardiovascular risk factors, should really be screened every 3 to 5 years. The USPSTF recommends yearly screening for those who are at increased risk. The ACC and AHA recommends that adults that have elevated blood pressure or stage 1 hypertension, who are actually not yet on any sort of treatment for their hypertension, to repeat the blood pressure every 3 to 6 months. How exactly do you diagnose hypertension? So when you're taking blood pressure in office, you should make sure that the patient is seated with their arm resting on an armrest or a table for at least 5 minutes. The measurement should really be taken with an adequate sized cuff on their bare arm, and their clothing should not be interfering with the measurement. Neither the patient nor whoever is taking the blood pressure should be talking during the measurement. And you should always take the blood pressure on the initial visit in both arms. Whichever blood pressure has that, or whichever arm has the higher blood pressure, is usually what is targeted for management. When you're measuring the blood pressure, really the patient ideally should not have exercised, smoked, or had caffeine within 30 minutes leading to that. When you're using a 24-hour ambulatory blood pressure monitor, an average blood pressure of greater than or equal to 125 over 75 defines hypertension, and that actually correlates with an office blood pressure reading of greater than or equal to 130 over 80. What exactly is an ambulatory blood pressure monitoring cuff? So ambulatory blood pressure monitoring, or ABPM, uses an electronic blood pressure measuring device. And this is used outside of the office and is actually a better predictor of cardiovascular outcomes. So this device can actually be worn for a total of 24 hours or sometimes even longer, and it checks the patient's blood pressure every 15 to 60 minutes and then records this. It's also important to remember that not all elevated blood pressure is a diagnosis of hypertension, and there are a lot of other causes. So for example, we talked about white coat hypertension, or initial evaluation with a new physician can cause elevated blood pressure, pain, or physical exertion. Dietary factors such as caffeine, alcohol intake, or alcohol withdrawal can cause hypertension. And a lot of medications can also cause an elevated blood pressure. So amphetamines, angiogenesis inhibitors, antidepressants, antipsychotics, steroids, cyclosporin, decongestants, a lot of dietary supplements, erythropoietin, NSAIDs, oral contraceptives, tacrolimus, and tyrosine kinase inhibitors can also cause elevated blood pressure. So here are some other important definitions to keep in mind. So secondary hypertension, which should really be considered in any patient that is diagnosed with hypertension. So some important historical details that can help you diagnose secondary hypertension include rapid onset of hypertension, really labile blood pressures, early age of onset of hypertension, so usually less than 30 years old, and an absence of family history. In their labs, frequently you'll see hypokalemia, hypercalcemia, and metabolic alkalosis. And this should really prompt you to think about other causes of their hypertension. So some other causes include, from a renal standpoint, any sort of renal parenchymal disease. So for example, polycystic kidney disease, chronic kidney disease, and renal vascular disease like fibromuscular dysplasia. From an endocrinology standpoint, primary hyperaldosteronism, thyroid problems, Cushing's disease, pheochromocytomas, parathyroid problems, all of those can cause secondary hypertension. Coarctation of the aorta can also cause secondary hypertension, as well as obstructive sleep apnea. There's also a resistant hypertension. So resistant hypertension is hypertension that is uncontrolled on 3 or more agents at optimal doses, including a diuretic, or controlled hypertension that is requiring at least 4 or more agents. So what you need to do when a patient has resistant hypertension is you should really be excluding office hypertension by obtaining the 24-hour ambulatory blood pressure monitoring like we talked about earlier, and make sure that they don't only have elevated office blood pressures. You should also look for other contributing lifestyle factors such as sedentary lifestyle, obesity, high salt diet, or high alcohol intake, as well as medications, because this can be masking the picture. So primary hyperaldosteronism is a very common cause of secondary hypertension, including patients that have stage 1 and stage 2 hypertension. So actually 11% of patients with stage 1 hypertension, 15% of patients with stage 2 hypertension, and 22% of those with resistant hypertension were found to have primary hyperaldosteronism, which is pretty significant. So some clues that can point you in this direction are very difficult to control blood pressure, hypokalemia, family history of early hypertension, and a stroke, as well as an adrenal mass. So the testing that you do for primary hyperaldosteronism is screen with the plasma aldosterone to renin activity ratio. And if it's elevated, so at least greater than 20, but especially if it's greater than 30, this can point you in the direction of this. Aldosterone level should also be greater than 10, and the plasma renin level should really be suppressed or less than 1. Another less common cause of resistant hypertension is pheochromocytoma. So let's do a question. So a 34-year-old female or 34-year-old woman is evaluated for hypertension. During the past 3 months, 2 blood pressure measurements in the healthcare setting averaged 150/90. During the same period of time, 3 blood pressure measurements obtained outside of healthcare settings averaged 128/78. She has no other pertinent personal or family history, and she takes no medications. On physical examination, blood pressure is 144/92 in both arms, pulse is 80, and respiration rate is 18. BMI is 22. The remainder of the examination is normal. Which of the following is the most appropriate management? A, begin chlorthalidone. B, obtain renal artery imaging. C, perform ambulatory blood pressure monitoring. Or D, recheck blood pressure in the office in 3 months. So the correct answer is C, perform ambulatory blood pressure monitoring. So white coat hypertension, which we spoke about earlier, refers to elevated blood pressure measured in the office, but normal out of office measurements. In adults that have untreated systolic blood pressure greater than 130, but less than 160, or a diastolic greater than 80, but less than 100, it's really reasonable to screen them using the ambulatory blood pressure monitoring at home, or make sure that they have a very reliable home blood pressure monitoring system. Chlorthalidone is not indicated. They have no indication for renal artery imaging, and really these elevated blood pressures should be confirmed. So what are the next steps after diagnosing hypertension? So what you need to do is evaluate the patient for the presence of other conditions that, when they're combined with hypertension, really increase their risk of morbidity and mortality from hypertension. So these are grouped into either modifiable or relatively fixed cardiovascular risk factors. So some modifiable risk factors include tobacco use, diabetes, hyperlipidemia, obesity, sedentary lifestyle, and an unhealthy diet. Some relatively fixed cardiovascular risk factors include like kidney disease, family history, their age, socioeconomic status, their gender, psychological stress, and obstructive sleep apnea. But some of these could be fixed a little bit. So important physical examination findings. So a lot of time you'll see hypertensive retinopathy, which is caused by, or which you'll see arteriovenous nicking or copper wiring. Sometimes you'll even see retinal hemorrhages when you do an eye exam. And this is caused by vasoconstriction and arteriolar narrowing. You can also hear a lot of vascular bruits if their hypertension is poorly controlled, including carotid bruits, renal artery bruits, femoral artery bruits. If you feel a left ventricular heave on exam, that can be indicative of left ventricular hypertrophy, which is a consequence of hypertension. If they have any heart failure that develops, you can hear an S3 gallop. You can see an elevated JVP and sometimes peripheral edema. If they have diminished pedal pulses on exam, you should really ask them about intermittent claudication, and that should point you in the direction of peripheral arteriolar disease. You should think about getting ABIs. If they have any other neurological abnormalities, you should consider a history of a stroke. Some additional lab testing that's important. So in terms of the laboratory studies, it's important to get a complete blood count, serum creatinine, GFR, sodium, potassium, calcium, bicarbonate, fasting glucose, lipid panel, and thyroid function. It's also important to get a baseline EKG to assess for left ventricular hypertrophy, which will also help you see if they have any evidence of heart failure as well. Urinalysis is also important, in addition to urine albumin to creatinine ratio, to help you determine if they have any other underlying kidney disease. Usually echocardiography is not recommended. Sometimes it can be helpful, and it should be done if there's any other evidence of left ventricular hypertrophy suggested by your exam or their EKG. So who needs treatment? So the 10-year atherosclerotic cardiovascular disease risk, or ASCVD risk, which we use in lipid management, can really help us determine which patients with stage 1 hypertension should be started on pharmacotherapy and which patients can work on lifestyle modification first. So the ASCVD risk is a calculation of the 10-year risk of having any sort of cardiovascular problem, such as a heart attack or a stroke. And the risk is estimated and calculated based off of your age, your gender, your race, cholesterol levels, your blood pressure, what other medications you use, if you have a history of diabetes and smoking status, and calculates the risk based off of all of these factors. So if you have a 10-year ASCVD risk of less than 10% and you have stage 1 hypertension, usually this is treated first with lifestyle modifications, and you give the patient 6 months of effort before you start thinking about starting pharmacotherapy. Patients that have atherosclerotic cardiovascular disease should be treated with pharmacotherapy as initial treatment, even if their ASCVD risk score is low, though. Patients that have a 10-year ASCVD risk of greater than or equal to 10% and stage 1 hypertension should be treated both with lifestyle modifications and pharmacotherapy initially. Patients that have stage 2 hypertension are typically started on lifestyle modifications and pharmacotherapy, and usually they're also started on 2 medications initially. What is the goal blood pressure? So the goal blood pressure is less than 130/80, regardless of comorbidity. So this applies to patients that have coronary artery disease, heart failure, diabetes, chronic kidney disease, and patients who are elderly. The ACC and AHA guidelines have one exception to this recommendation, though. They say that it's unclear if patients that have a history of a stroke or TIA, and they don't have a history of hypertension, if they really benefit from treating the blood pressure unless it's greater than 140/90. So that's the one exception. The kidney disease society guidelines are actually different from the ACC and AHA guidelines, and they recommend treating patients that have chronic kidney disease and are not on dialysis to a more aggressive blood pressure goal of less than 120. And normally they recommend starting an ACE inhibitor or an ARB. So lifestyle and dietary modification. So lifestyle modifications refers to any changes in diet and exercise with the goal of reducing blood pressure in both patients that have a diagnosis of hypertension and without. So poor eating habits and lack of exercise will increase your blood pressure, but if you're eating healthier and exercising regularly, this will decrease blood pressure. So for every 1 kilo of weight loss in the overweight or obese patient, blood pressure will decrease by 1 millimeter mercury. The ACC and AHA hypertension guidelines recommends optimal sodium intake of less than 1,500 milligrams per day. They also recommend diets high in potassium, as this will reduce blood pressure by 4 to 5 millimeters mercury in patients that have hypertension. But instead of taking potassium supplements, they just recommend increasing your dietary intake of potassium with fresh fruits such as bananas and oranges. You can also eat a high potassium diet with beans, raisins, prunes, avocados, and tomatoes. The AHA/AC lifestyle management guidelines also say that eliminating physical inactivity will reduce coronary heart disease by 6% and will increase life expectancy by 0.68 years. Aerobic physical activity, specifically sustained exercise for 90 to 150 minutes every week, reduces systolic blood pressure by 5 to 8 millimeters mercury. Resistance training is also great for reducing blood pressure. So the DASH diet, or dietary approaches to stop hypertension, which is a diet of fruits, vegetables, low-fat dairy foods, which is also low in saturated and total fat, can reduce systolic blood pressure by 11.4 and diastolic blood pressure by 5.5, which is very significant. They also noticed that patients who were on the DASH diet that did not have hypertension also had lowered blood pressure. So if you look at this table here, it talks about increasing the macronutrients of the vegetables, fruits, low-fat dairy, whole grains, nuts, poultry, and fish, but decreasing sweets, fats, and these micronutrients. The Mediterranean diet actually first came to attention in the 7-country study, which was an epidemiologic study of cardiovascular outcomes in actually all the USA, Northern Europe, Southern Europe, and Japan. And they noticed that cardiovascular outcomes were a lot lower in Southern Europe, and they attributed this to the Mediterranean diet. So this diet is low in total fat, saturated fat, it's high in fiber, high in omega-3 fatty acids, and it reduces systolic blood pressure by 6 to 7 and diastolic by 2 to 3. So this is a summary of all the lifestyle and dietary modifications that we talked about. So weight loss and how much it can change your blood pressure, the DASH diet, sodium restriction, high potassium diet, aerobic exercise, and then resistance training. So these are all beneficial and very helpful to reducing blood pressure. So we can move on to pharmacotherapy. So choosing an agent or multiple agents really depends on how high the blood pressure is, the patient's race, and the patient's comorbidities. Usually gender is not a consideration when you're trying to choose which antihypertensives to use. But clinical trials have shown that antihypertensive medication therapy is associated with up to a 40% reduction in stroke, 25% reduction in MI, and 50% reduction in heart failure. So first-line agents for the treatment of a typical patient with hypertension include diuretics, calcium channel blockers, ACE inhibitors, or ARBs. Patients with stage 1 hypertension are typically treated with one single agent to start with. Patients that have higher blood pressure or stage 2 hypertension should really have initial treatment with 2 antihypertensives from 2 different classes. If you do initiate a diuretic, electrolytes and their kidney function should ideally be checked in 2 to 4 weeks after you start the medication. Clinical trials of antihypertensive medications showed very comparable effects on cardiovascular outcomes with one exception. So for the prevention of heart failure, initial therapy with a thiazide diuretic was actually more effective than a calcium channel blocker or an ACE inhibitor. And an ACE inhibitor was overall more effective than a calcium channel blocker. So first we can talk about ACE inhibitors and ARBs. So ACE inhibitors like captopril, lisinopril, enalapril, benazepril, and then ARBs such as candesartan, losartan, valsartan, and irbesartan. All of these can cause hyperkalemia. You should also avoid concurrent use of both of them, and they're contraindicated in pregnancy. As you know, ACE inhibitors prevent the conversion of angiotensin 1 to 2, and it disrupts the RAS system and causes relative vasodilation. And ARBs block the vasoconstrictor and aldosterone secreting effects of angiotensin 2. It blocks the binding of angiotensin 2 to the AT1 receptor, which is found in many tissues. So ACE inhibitors and ARBs, clinical trials have reported pretty similar efficacy of both of them, and it reduces blood pressure, progression of albuminuria, and chronic kidney disease, and it reduces the risk for cardiovascular events. Patients with kidney disease and albuminuria and proteinuria, you want to treat preferentially with these agents. When you are using an ACE inhibitor, you can typically see up to a 30% decline in the GFR, which is acceptable and really should not lead you to discontinue therapy. If you do have hyperkalemia that develops on an ACE inhibitor or an ARB, always try to use dietary modifications first to control the potassium. And just as a reminder, don't use ACE inhibitors or ARBs in combination with each other. So thiazide diuretics are another class of medications that are indicated for management of hypertension, and they act by inhibiting the sodium chloride cotransporter in the distal renal tubular. Chlorothalidone is the preferred thiazide diuretic because it overall has a longer half-life than the other diuretics. Some important side effects to monitor for are mostly electrolyte abnormalities, so hypokalemia, hyponatremia, hyperuricemia. You can also see some hyperlipidemia and hyperglycemia. Try to avoid these in patients that have gout. So combination therapy with more than one drug class sometimes is necessary to control blood pressure. So guidelines recommend combination therapy with 2 first-line antihypertensive drugs of different classes for adults with stage 2 hypertension and an average blood pressure of 20 or 10 above their blood pressure target. There's really no specific recommendations for the best combinations, but some data suggest ACE inhibitor and calcium channel blocker combination can be more efficacious than an ACE inhibitor thiazide diuretic combination. You could also use the thiazide and calcium channel blocker combination as well. So another question, a 42-year-old man is evaluated during a follow-up visit for recently confirmed primary hypertension. Hypertension was confirmed with multiple home blood pressure monitoring readings that averaged 148/98. Chlorothalidone was initiated 1 month ago, and home blood pressure monitoring showed readings above target despite adherence to lifestyle interventions and medication. He has no other medical problems and takes no other medication. On examination, blood pressure is 144/94 and pulse rate is 72. Other vital signs are normal and BMI is 22. The remainder of the exam is normal. Lab studies show a serum creatinine level of 1 and a serum potassium of 3.5. Which of the following is the most appropriate additional treatment? So the answer is A, amlodipine. So except for the combination of ACE inhibitors and ARBs, regimens containing a combination of thiazide diuretics, calcium channel blockers, ACE inhibitors, and ARBs are preferred to achieve blood pressure goals in patients requiring dual antihypertensive therapy. The other answer choices that were listed, doxazosin, hydralazine, and metoprolol, are not recommended for initial therapy or as add-on. So calcium channel blockers are another class of medications. Two classes, so there's dihydropyridines and non-dihydropyridines. So dihydropyridine includes amlodipine, felodipine, and nifedipine, and the non-dihydropyridine are diazepam and verapamil. There's really no data that supports the use of one class over the other for hypertension, although long-acting dihydropyridines are usually chosen. So the non-dihydropyridines have a more pronounced cardiac effect, and it can cause diminished contractility or negative inotropy and AV nodal block. So you should really be using these with caution in patients that have heart failure with a reduced EF, sick sinus syndrome, or a history of AV block, and are also on beta blockers. So in patients that have difficult to control blood pressure, after you've ensured that they are adhering to their medications and you've maximized their diuretics, you can consider adding a mineralocorticoid receptor antagonist. There was one study of patients that had uncontrolled hypertension on 3 different agents that found that adding spironolactone 25 to 50 milligrams a day was superior to other classes of agents when used as a 4th agent for their regimen. So how do we adjust the dose? So there are 3 strategies for possible dose titration. So first is maximizing the first medication dose before adding in a second agent. The second is adding a second medication before reaching the maximum dose of the first. And the third is start with 2 medication classes separately or as fixed dose combinations. There's really no trial to compare all of these strategies. So really you should talk to your patient and see if they're having any dose-related side effects and kind of see if there's anything from their standpoint that you can adjust for your doses. So normally there's diminishing return in blood pressure lowering if you're going from a dose of 50% to 100% of maximum. It's really unlikely that increasing the dose from 50% to 100% of maximum will result in an additional even 5 millimeter mercury blood pressure reduction. So you really might need to add an additional agent if you're already at that point. So special populations. For women, hypertension prevalence is lower in women that are less than 50 years of age compared with men, but the prevalence increases with older age and eventually becomes pretty similar in both genders. Women of childbearing age who anticipate pregnancy should not be on ACE inhibitors or ARBs because of the risk of urogenital developmental abnormalities. You should ideally be transitioning these women to methyldopa, nifedipine, or labetalol during pregnancy. It's also important to remember that oral contraceptives may be associated with a modest increase in blood pressure, but usually this gets better once you stop the oral contraceptives. So our next question, 52-year-old woman is evaluated during a follow-up visit for hypertension management. She has a 10-year history of type 2 diabetes, and diabetic retinopathy was diagnosed 1 year ago. She also has obesity and hyperlipidemia. Medications are hydrochlorothiazide, metformin, empagliflozin, and atorvastatin. On physical examination, blood pressure is 138/86, and other vital signs are normal. BMI is 32. The remainder of the examination is unremarkable, and labs are shown below. Which of the following is the most appropriate treatment? So amlodipine, B atenolol, C doxazosin, or D losartan. So the answer is D, losartan. So the ACC and AHA recommends a target blood pressure of less than 130/80 for patients with hypertension and diabetes, and she was above that goal. In patients with diabetes and hypertension, all first-line classes of antihypertensive medications, so diuretics, ACE inhibitors, ARBs, and calcium channel blockers are useful and effective. You really want to be using ACE inhibitors and ARBs when patients have hypertension and diabetes and albuminuria. So albumin creatinine ratio greater than or equal to 300. Among the drug classes, ACE inhibitors and ARBs have the best efficacy on urinary albumin excretion, and they reduce disease progression. So just like we talked about, the goal is less than 130/80 for blood pressure management for patients that have diabetes. And without chronic kidney disease, the first line management for hypertension is basically similar to any other patient that does not have diabetes. But the American Diabetes Association recommends that patients that do have diabetes and hypertension and a 10-year ASCVD risk less than 15% should really be treated to a blood pressure of less than 140/90. And if their ASCVD risk is greater than 15%, then less than 130/80 is their goal. And ideally, all of these patients should be on an ACE inhibitor or ARB at the maximum tolerated dose. So older patients, the prevalence of hypertension increases with age and is as high as 60 to 80% in patients that are greater than 65. The target systolic blood pressure goal for these patients who are greater than 65, according to the ACC and AHA, is the same. It's less than 130 systolic, whereas the American College of Physicians and American Academy of Family Physicians actually recommends a target systolic of less than 150 when patients who are greater than or equal to 60 years old. So overall, antihypertensive medications that you start in older patients should really be started at lower doses. You should monitor their blood pressure a little bit more closely and watch for adverse events, because older patients are at higher risk and more prone to interactions between medications, hyponatremia, hyponatremia from diuretics, and then orthostatic hypotension as well. And then this is just kind of a table of other special populations to consider. So for example, patients that have angina, you can use beta blockers. Patients that have aortic stenosis, you should really be starting with ACE inhibitors or ARBs, diuretics, and start with the low dose and gradually titrate upwards. Patients that have AFib, try to use an ARB to reduce the risk of a recurrence based on their ethnicity. If they're Black, then using a thiazide diuretic or calcium channel blocker generally works better, but it's just important populations to consider. And these are my references. Does anyone have any questions?
So anyone have any questions? I saw one question in the chat bar.
Oh yeah, let me look.
Caroline. She mentioned that I'm just curious to know that in what case the doctor decided to cut a gastric for a patient. Cutting gastric is a common or popular medical care in the US or not?
Let me ask Carolyn.
Yeah.
So the question is, I'm curious to know that in what cases the doctor decides to cut gastric for the patient. Cutting gastric is a common or popular care in the US or not?
Yeah, so is this question about gastric bypass, like the Roux-en-Y? So that would be BMI greater than 40. I think initially when you assess your patient, you do work on those lifestyle managements to see if they can lose any weight on their own using pharmacotherapy. But truly, if their BMI is greater than 40, you would want to refer them to like the weight management clinic specifically or the surgeons.
Okay. Thank you. And nowadays I heard that so many dietary approach like fast and like they eat the supplement instead of the meal. So is that help for the dietaries or that is work? Would you recommend the patient to do like dietary approach like fast?
Yeah, so in terms of dietary approaches, it's really just a caloric deficit. So, depends on what they would like to do in terms of decreasing their calories, definitely recommending a healthy balanced diet. In terms of supplements, such as like herbal supplements and other things like that, in the United States, it's not FDA approved, so we actually don't know what goes into all of those supplements. So we would not recommend those to patients, like the fast losing weight supplements.
Okay. And for the hypertension, normally, it's just curious, normally why the adult is more get like this type of disease more than the younger, like the children or the kids?
Oh, that's an interesting question. I'm not sure why people who are older are more prone to hypertension. I wonder if it has to do with just the like musculature and like the arteries, probably just, gets weaker or makes them more prone. But yeah, I'm not 100% sure.
Okay, so, yep. Anyone else have any questions? We have Naima here. Would you like to ask any question?
Well, thank you for your presentation.
I'm sorry, we cannot hear you well. Can you volume up? So I don't think she have the questions. Okay. All right. So I think that's all for the webinar for today. And thank you very much for Caroline and C for their information on hypertension and dietary. And yeah. And thank you. Okay, and Miss Farina have something to say.
And before you're going, please help us to do a satisfaction. Yeah, I already sent link in the chat group. So shall we take a capture of a photo? Everyone is can open the camera. Naima, can you open the camera, please? Yeah. Kani.
Okay, so maybe I count 1, 2, 3, and then Miss Farina will capture the screen.
Okay.
Everyone ready? 1, 2, 3, smile. All right. Thank you.
Oh, goodness.
Okay.
Okay.
Doing it right.
Yeah, that's good. 1, 2, 3. Okay.
Thank you.
Thank you. Thank you. And see you soon.
Thank you.
Bye. Thank
Thank
you.
you so much.
Okay, bye.
Bye.